Thank you, Kumar, for a very, very kind introduction. I am indebted to you for accepting me for this instruction course. Now, my previous speakers have dealt in details about diabetic retinopathy, both medical as well as surgical treatment. And in this last talk, I would like to point out the first dictum I would like to highlight is that not every retinal lesion in a person with known diabetes is diabetic retinopathy. So we have to keep our mind open. Even if the patient is diabetic for years together, he may still harbor some other comorbidity and may have that effect on the retina. So I think we have to keep a open mind and the patient was with blurred vision and he is a diabetic. My slides are not moving. 1 minute.
We have lots of time. You can settle it.
Yeah, no, my slides are not moving. I'm just checking that. Yeah. So let us look at this situation here. Now, this patient is again a known diabetic for years together, presents to you with this picture of multiple retinal hemorrhages. And looking at his status, you feel, general ophthalmologist will feel that this is a non-proliferative diabetic retinopathy with multiple hemorrhages in all quadrant, maybe a severe form. But once we investigated the patient, other central systemic status, FFA, OCT, this turned out to be a non-ischemic CRVO. A patient like this who presents to you with blurred vision, hard exudate at the fovea, again, you may think that this is a diabetic maculopathy, but again, a proper examination, investigations. I can see in this slide here on the right that there is, in the FFA, you see a sectorial microvascular anomalies. This is suggestive of tributary retinal vein occlusion in the inferior temporal quadrant. A similar situation here. If you just look at the posterior pole, as has been highlighted in the earlier talks also, you would feel that this is a diabetic maculopathy with hard exudates, microaneurysms. But if you look closely at the posterior pole, you can see that there are hard exudates, but above that, there is this vein which has got occluded. Hence, this is just not a diabetic retinopathy, but a superior temporal branch vein occlusion with changes at the macula. Now, this is an interesting case. We saw this lady about 2 years before this picture, when we diagnosed her with a particular condition and advised her treatment and investigations, but she didn't follow up with us and came to us after 2 years. And when we did her angiogram, this was the picture. So if you look at this angiogram only, you would feel she's a known diabetic. So you'll feel that this is a proliferative diabetic retinopathy with extensive NVD and NVE. But actually, she was diagnosed based off hemorrhagic CRVO when we first saw her. And over the years, the CRVO developed this type of a neovascularization. Now, again, in this case, if you see, just if you have a cursory look, you will feel there is a few retinal hemorrhages around the macula, so probably a early diabetic maculopathy. But again, if you do a proper examination, investigate the patient, you see that there are a lot of microvascular anomalies in the lower half of the macula, and further the periphery, there are definitely extensive areas of capillary non-perfusion. So this is a case of inferotemporal branch retinal vein occlusion in a person who has diabetes for a long time. So I think it's very important for us not to presume that a person has, if he has some changes, it is only diabetic retinopathy. Now again, a case of a young male, about 45 years old, who had not a very good controlled diabetes, and he had with this picture in his right eye, some soft exudates. Again, you would think of a mild non-proliferative diabetic retinopathy. But if you look at his other eye, again, similar, lot of soft exudates, but look at the macula. There is hard exudates coming in a star fashion with some fluid in the macula. So when we investigated him, did his blood pressure, we checked his blood pressure ourselves, his blood pressure was very high. So this is a case of hypertensive retinopathy, which may come along with his diabetes. So I think systemic evaluation, and even as a ophthalmologist, you have to be very careful. Recently, I had a very young boy, 25-year-old, non-hypertensive, non-diabetic, who presented with extensive retinopathy. And his blood pressure, when we checked immediately, was something like 240/160, had to be admitted in the ICU the same day. So I think we have to be very careful and keep an open mind. So this patient presented, a known diabetic, presented with sudden loss of vision, and you can see clearly that there is a opacification of the macula, a cherry red spot. So no doubt this clinically is a central retinal artery occlusion. So these arterial occlusions can come with diabetic retinopathy, or like a branch arterial occlusion when this patient presents to you with an upper half visual loss, sudden onset. So he has a inferotemporal branch retinal artery occlusion. as mentioned earlier, if you have a patient who presents with such extensive hard exudates, you feel that probably he has a chronic diabetic maculopathy. But if you look closely, there is some dirty white membrane here, some fluid here. So after investigations in the form of FFA, OCT, and ICG, this turned out to be an PCV. Again, a confusing situation when you have excessive hard exudates, but they may not be typical hard exudates. They may be just reticular drusen or drusen scattered all over. And this, again, when on investigations with FFA and OCT and OCT angiography, turned out to be an early neovascularization which needed treatment. And subtle hemorrhages like this should prompt you to think not only of diabetic retinopathy, but also of retinal angiopathy or angiomatous proliferation, where you can get these small hemorrhages right at the foveal center. Again, a comorbidity which is not very common is the microaneurysms, which if you see here, seen very clearly, and they lead to a lot of exudation. So if the microaneurysm is not very large, you may miss it, and you may just think this as a diabetic maculopathy. And again, in this, extensive hard exudates, but there is a microaneurysm here which confirms the diagnosis. A patient may present with retinal hemorrhages, and you may think this is a part of his diabetic retinopathy, but you have to see closely that there are some rot spots here. And when we had him investigated, his hemoglobin was only 4, and we had to refer him to a hematologist for his treatment. So anemic retinopathy can also present in patients with diabetics, and maybe sometimes along with diabetic retinopathy. And lastly, I show you this case, an 80-year-old lady who came to us with blurring of vision only in the left eye. When you examined her, we saw extensive retinal hemorrhages all around, but no hard exudates, no new vessels. Her other eye didn't have much of diabetic retinopathy, so we investigated her. I had a suspicion of carotid artery occlusion, so we got her carotid angiograph, carotid Doppler also, and she turned out to be a case of ocular ischemic syndrome. So I think these all entities should be kept in mind. And in ocular ischemic syndrome, FFA plays a very important role, and that will help us differentiate it from a typical diabetic NVDA or severe NPDR. So to conclude, we have to keep an open mind while examining all diabetics. A proper systemic history, appropriate investigations would lead to a proper diagnosis and treatment of comorbidities, along with treatment of diabetic or any diabetic retinopathy if needed. Thank you.